And whenever we do that, we always test the edges of the area we removed, and those edges are called the margin. And on our first check, right, so we know that we took about half of the swallowing portion of the throat, which is called the pharynx, half of the pharynx and the larynx removed together, and they check the edges. There's actually no evidence of cancer crawling on the mucous membranes. However, under the mucous membranes, within the lymphatics and blood vessels, they did see tumor starting to spread. Okay, what that meant for us is, unfortunately, could not leave any of his swallowing portion of the throat. Okay, so we performed what's called a total laryngopharyngectomy. All right, but that doesn't make that much difference because we were still going to rebuild the throat anyways. And so what we did, Dr. Wong, my partner, harvested tissue from the left thigh and just made it into a tube. And so now he's got a tubed flap that connects the esophagus to the mouth. Mm-hmm. And that over time, hopefully in a week or so, we're going to start him eating again. I think more importantly, the lymph nodes in the neck we had to address, obviously. And as you guys know from the scans, the right neck was pretty diseased. In fact, the right neck lymph nodes that had cancer inside were completely surrounding his jugular vein on the right. And we had to sacrifice the jugular vein on the right. Okay. We sacrificed that. We also sacrificed a large nerve called the vagus nerve, which is used for sensation of the throat and speaking, which he doesn't need anymore, so it doesn't really make a significant impact for him. But we were able to clean the carotid, so the carotid artery was completely intact and spared. Luckily, human being only needs one jugular vein, which he has on the left side, and is totally normal. So he shouldn't really notice anything being missing, which is good. But what that does mean is he most definitely will require both chemo and radiation therapy afterwards. Right? And so he, the severity of his tumor was such that I think he needed basically everything: surgery, radiation, and chemotherapy. So I certainly feel that radiation chemotherapy alone would not have cured this problem. But everything honestly went well. We didn't lose very much blood. We were able to save the nerves that control his shoulders, the nerve that control his tongue. Dr. Wong is putting finishing touches on the closure now. And then obviously he's going to have a feeding tube in place for the next week or so. And then on day 7, if everything goes according to plan, we'll test his swallow function, make sure the new throat we built him works and isn't leaking. And if so, we'll take the feeding tube out and start him on a liquid diet at that time. Okay. Usually, people will go straight from the operating room to the ICU for 2 days, and then they'll go to a private room thereafter for 5 more days. We'll test the swallow, and then get him out afterwards if everything goes well. Okay. Any questions for me?
Probably a million, but I can't think of any right now. Wow, that's a lot.
I think everything went kind of straightforward according to plan. We did exactly what we needed to do.
Right.
No hiccups aside from the fact that I removed the remainder of his swallowing throat, but again, we were going to reconstruct probably 90% of it anyway, so now I should reconstruct 100% of it this time.
Okay. So it's just as good as if you hadn't have had to reconstruct the whole thing?
Pretty much. I mean, as long as he heals, it'll be just as fine.
Yeah. Okay. So that's all great. Just, disappointed there was so much more cancer than we were.
More than you can see on the CAT scan,
right?
For sure.
Okay.
But
will y'all do a PET scan while he's here?
No, there's no need for a PET scan until a chemoradiation is completed. So usually about 4 to 6 weeks from now, I think, is that a wife?
Yeah.
Okay, come in. A chance to meet her. I'll come in.
Sorry.
That's okay.
I've got it up to this point, so.
All right, I'm Dr. Liou. I know we haven't met yet. Hey there, Dr. Liou. It's good to meet you. Also, I was telling Sister, we're pretty much finishing up now. Everything went well with the surgery. There were a couple of not necessarily surprises, but obviously it was a very advanced tumor that was affecting the voice box. But when I explained things to him, we knew that it was not just affecting the voice box. It was in fact growing into the swallowing portion of the throat as well. Right, so when you think about the throat, I think of it as a funnel, right, with 2 spouts coming out. The front half of the funnel is the voice box, which leads to the windpipe. The back half of the funnel is the swallowing portion of the throat called the pharynx, and it leads to the esophagus. Right, so during the surgery, we obviously have to remove the voice box, but we knew already we were going to move about half of the swallowing portion of the throat. when we take it out of the body. First thing I do is send it to the lab for them to check the margins, the edges of what I removed. And even though on the actual mucous membranes, the wet part, right, that makes secretions in saliva, we cleared the cancer there, they saw that there were cancer cells traveling within the lymphatics in the soft tissue itself, deep to the lining. And so in order to get completely around it, knowing that I'd already taken the majority of his swallowing throat anyways, we completed what's called a pharyngectomy. So I took 100% of the swallowing portion and the voice box of the throat and removed that. For us, it doesn't really change anything. We're going to rebuild the throat anyways. Just means you got to take more skin here and turn it into a tube to connect his esophagus to his mouth. And my partner, Dr. Wong, has finished that portion already. And so now we're literally just closing. The other thing I identified was on the right neck, he had some pretty significant lymph node disease. So cancer had spread to the lymph nodes in the right side of the neck. We knew that beforehand. What I discovered during the surgery, however, was that they were inseparable from his jugular vein on the right. In fact, encircling it almost 360 degrees. And so we did have to remove the jugular vein on the right side of the neck. We were, however, able to clear the carotid arteries. The carotid is fine. And I was telling his sister, you only need one jugular vein to be normal. And so he actually probably won't even notice that he's missing the one on the right because the left one's totally intact. Left neck lymph nodes, by my naked eye, looked okay. I didn't see anything particularly strange. However, all of these will be checked in the lab, in the pathology lab, when they run the tests on everything. So from here, we still got probably about an hour left to close up everything, closing the leg, closing the neck. He'll have drains coming out of both sides of the neck as well as drains coming out of the leg to, number one, watch for saliva leaking through our reconstruction, but more importantly, to get all the excess fluid from surgery out. He now, right, the windpipe opens in the front of the neck permanently. So that's how he's going to breathe. We're going to send him to the intensive care unit tonight. They usually stay there for 48 hours. So today is Thursday, so he'll be there all day Friday, all day Saturday. Sunday, we'll get him to a private room if everything goes according to plan. He will be getting nutrition through a feeding tube that goes from the nose down to the stomach. Usually, healing time is only a week, and so we prefer a temporary feeding tube. On day 7, we'll test the swallow function by what's called an esophagram. If it shows that the swallowing portion of the throat is healing well, there's no leaking of fluid out of it, they will remove the feeding tube and start him on a diet. And after that, they can usually go home.
Doctor, you just so thank you so very,
You're very welcome. Yeah, I know it's been a kind of a roller coaster. He came in here being unable to breathe. We did an emergency surgery for him with him wide awake. And obviously we were able to get him on pretty quickly and get this definitively taken care of. Now, based on our findings, what we saw today during the operation, he will require radiation chemotherapy still, right? It's a much different experience having had the surgery. People actually tolerate it a lot better. Especially from a swallowing perspective and eating perspective, which is why we wanted to do this to begin with. But we do know that the advanced nature of his disease, he needed everything. I think chemoradiation would have not been enough if the original plan was carried out. But now that we kind of got all the gross tumor out of there, I think radiation chemotherapy will work a lot better now.
Now, will the chemotherapy and radiation be done here?
So that's up to you all. Obviously, I work for Baylor College of Medicine, and I'm going to for sure send you referrals to our team here. But when you get radiation, it is a Monday through Friday job, 5 days a week for 6 weeks. You get breaks on the weekend.
We do have an oncologist 20 minutes from our house.
So I'll leave that up to you all. I kind
She
of also...
wanted to ask us to install some kind of calf.
Port, usually a port. That can be done. So usually chemoradiation does not begin for at least 4 to 6 weeks from surgery. So you don't want to do it before 4 weeks. Going to maximize his healing. You don't want to wait beyond 6 weeks because we don't want cancer growing back should there be microscopic disease that we can't see. So that's kind of the golden window to initiate those things. So you can get, hopefully he won't be here much over 7 more days. So he's got plenty of time to get that arranged.
Can I get Dr. Anna to call? Was she liaison with you, or how will that happen?
So this is kind of up to you all. Like I said, here's the reality. At the academic center and the hospitals here, we're all sub-specialized, okay? Like Like, I don't take out tonsils. I don't do sinus work. I only do big cancers, even though I'm an ENT doctor. My radiation doctor doesn't treat prostates, doesn't treat breasts, doesn't treat colon. He only treats this type of cancer, right? And so when you drive a Ferrari, you could probably take it to Midas down the street. They could probably fix it, but is that what you want to do, right? And I always leave it to the patients, because the other reality is people can't drive an hour and a half to the med center 5 days a week. I understand
I wish
that.
it was only an hour and a half for us.
Right. So if it's not feasible, then I'll be more than happy to get her contact information, give her a call. More importantly, all she needs to see are the pathology results. That's kind of how we communicate. And once we get that back, we should take about 7 to 10 days. She should know exactly what he needs based on his preoperative scans, his pathology results. Pretty open book.
Okay. I can get you that information.
Yeah, we'll make sure we get all our contact information so I can communicate and send faxes and all the reports and things
Because that
like
would
that.
help so much. I don't drive,
Sure.
so this will be so much easier for me and for him maybe too.
For sure.
That traffic is so awful.
Yeah. No, I understand.
Because we're coming from Tomball.
Yeah. That's pretty far out there, so yeah, I don't blame you. I understand. It's not easy to get down here, so we always kind of make accommodations for that.
Well, everybody here has just been fantastic, and
Good.
we're so happy we got you.
Good. I'm glad you had a good experience here, and this is all that we do. So I think I'm very pleased with how surgery went today, and I'm glad that he decided to agree to move forward, because I don't think it much lasted much longer, to be honest. And from the breathing perspective, I'm glad he showed up when he did, because he was breathing through windpipe that big. He's very uncomfortable, so I think he'll feel a lot better.
Yeah, I think so too.
Okay.
And that 4 to 6 weeks before he starts the treatment, does that start when he goes home, or does it start now? Okay, so 4 to 6 weeks.
From now, he should start his radiation chemotherapy. That's the ideal window.
Okay. And I know you gave me a good ballpark before. If he only had radiation, can you throw any number of months out there for what you think it might take yet? No, for both. Okay. So we don't know how long he'll be without his speech.
Correct.
Okay.
So, with both, 3 months. Yeah. So
both 3 months.
Yeah,
okay.
Yeah. So they're administered concurrently. So you get chemo and radiation at the same time.
Okay.
Yeah. Usually it's either every week or every other week infusion, and then 5 days a week of radiation. So the chemo is not a big part of it.
So it sounds like it's just adding a month on to what we had originally thought.
Probably
maybe.
so.
Yeah.
Probably
And
so.
then so after that he comes back for his.
As an outpatient, we place the prosthesis in and out.
Wonderful.
Yep. Even for those prostheses, no restrictions, no dietary change. Come, go to sleep, we put it in, and then 1 week later we start using it.
Wonderful,
Yeah.
wonderful. Ooh.
And before he leaves, we'll kind of get him the electronic voice box and help him learn how to use that.
Great.
All right. So you guys, if you want to actually, it's still going to be some time. I think they need about an hour to finish closing. Then probably have 30 minutes, 45 minutes for transport. Where he's going to go is the surgical ICU. I think that's where he was before.
Well, no. This time they said it was Cooley.
6 Cooley A.
Yeah.
So if you go back down to the first floor, I encourage you to get some dinner or something, take a break. Go down the first floor, go to the green elevators, go up to the 6th floor. There's a waiting room there, and that's where he's going to be for the next 2 days.
Okay.
Okay?
Yeah.
All right.